So we start with introduction to palliative care just before going to the basics or my slides. As I said, uh, it's inside you. Palliative care is inside you. Just need to find certain answers to the questions that is always there inside our mind. For example, there's a saying that every problem is tagged with a solution. The only task that we as human beings need to do is that find that solution, find the place where it is tagged. So I would say, palliative care has answers to many questions, many problems. It is a solution to many problems. The only thing that we need to know is to find that particular answer. So, this is a definition by the WHO, and it says that it is an approach which improves the quality of life of patients and their families facing the problems associated with certain life threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, which are physical problems, psychosocial problems, and spiritual problems. So, the crux of this particular definition is that we need to focus on the quality of life of our patients, and those patients, their problems would be more or less associated with the life threatening illnesses. There may be life limiting illnesses also. And we need to have an approach where we will have to prevent and relieve the suffering that is associated with these kind of illnesses. So this is a proper definition that has been coined by the WHO. Now, where does palliative care actually start from? How did it start? So in the olden days in India, the traditional healthcare used to reach people at their homes. I mean, you must be hearing stories from your grandparents that the doctor used to come to see patients at home, and he used to carry his bag. Maybe one of his compounders or a nurse used to accompany that doctor, and that used to be such a positive thing in Indian medical history. There was nothing like patients going in ambulances to hospitals. It was always the doctors who used to come to patients' homes, and that is where healthcare started. I mean, it started from homes. So you can understand the amount of compassionate care that was there in our doctors, doctors of India, which perhaps after modernization has been lost a little, but I wouldn't say it is diminished. It's still there. I do home care for my patients who cannot come to my clinic or my hospital. And I'm sure out of this lot that I'm interacting today, you are also, many of you must be doing some kind of little bit of home care, for your patients also. So traditional healthcare in India used to be in patients' homes, in people's homes. And that's a part of palliative care, and that's really something that is ingrained, imbibed in our traditional healthcare. So, but in the West, the system was a little different. And what used to happen is that maybe in the 18th century or even before that, when there was no cure to certain illnesses, very terminal illnesses, people used to go for pilgrimages to, maybe a church or the highest order of Christian belief. And on the way to those places of worship, they would actually stay in certain places where they might sometime succumb to their illnesses. And those particular rest homes or places where they used to stay or spend their nights, they later on started to be termed as hospices. So that's where that's the concept where the hospice care started. And it was related to the sisters of charity, mainly the people of the church, who were dedicated to God, dedicated to the highest belief of Christianity, and they would actually serve those old and dying people. And that's where the concept of hospice started in the West. So you can see the difference between Indian traditional healthcare and the Western culture. It has been really different, but the crux of the thing, the main connect of both the things is that we used to the healthcare used to be in and around the people who were old, dying, suffering from certain illnesses which are not curable. On your right, you can see Dame Cicely Saunders of the UK. Till this time, because of your inquisitiveness, I would assume that you've already, tried reading about Dame Cicely Saunders of UK. Just to be brief, she is the founder of the modern palliative care movement of the world. She was a nurse, and she used to take care of the soldiers wounded in the Second World War. And she started her palliative care journey started after looking at the wounded soldiers, the pain that they had, the use of morphine for those soldiers. And at the same time, she started caring for those people who used to die on certain camps, and then the whole process that was inside her started to tell her that she should go for a medicine degree, and she became a doctor after that, and she specialized in palliative medicine. She is the founder of St. Christopher's Hospice, which is supposed to be the Mecca of palliative care physicians. I would recommend all of you to once visit St. Christopher's Hospice in London, if you at all have, if you at all go to UK anytime in the future. So modern palliative care movement was started in the UK. And I'm sure you all know that Dr. M.R. Rajgopal is the father of palliative medicine in India also. And he's started Pallium India, and that's what we are learning today. The legacy starts from Dr. Rajgopal. So it started in the 1980s in India, palliative care, and mostly as a non-governmental activity. So this is a little brief about the palliative care starting in India. Contrary to the popular belief that many people have, palliative care is not only for cancer, it is not only pain management, and it is not only for terminal illness. So we need to know and understand and take away this message today that palliative care is for all serious health-related suffering. So it can be in a humanitarian crisis situation also. Palliative care had a lot to do during the tsunamis. If you go through Google Scholar and search about humanitarian crisis and palliative care, you will find hundreds of papers, hundreds of research articles that give you an idea and overview of how palliative care can benefit in humanitarian crisis. So this is just an example. So there are other situations where palliative care physicians, palliative care workers, volunteers, nurses can actually contribute towards serious health related suffering. And the most important thing that makes palliative care different from others is that we take the care of families also along with the care of patients. So it relieves suffering and improves the quality of life of both the patient and the family. And at the same time, it takes care of the quality of life as well as the quality of death. Um, in my early days, when I was a student of palliative, I'm a student of palliative. I'm still learning. I had listened to a talk by a very interesting person who's also one of the leaders of palliative care in India, Dr. Abhijit Dam, and the the thing that he had told that day still resonates in my mind. And he said that we always think about life insurance. Do we at all think about death insurance, insuring our deaths? How are we going to die? What is the process that we'll go through while dying? So that is something to be pondered about. I haven't found an answer as yet, but I'm sure that, after this particular discussion today with you, maybe some of you could actually come up with some answers to this interesting question. So I just need to, give you some little idea about what I personally think about palliative care, how I would, want to relate. Maybe many of you might want to agree with me on this. There's a certain thin line between how we define disease and how we define illness. So as you can see in this picture, this is a ghastly picture of a 40-year-old, 42-year-old manual laborer, and he has a cancer of the cheek. There's a large wound there. He lives with his wife and 2 children, and the children are really small. One aged 9 and another one is 5. And he comes to you with pain and a foul-smelling wound on his cheek. So I would generally see the disease as the oral cancer, which is the squamous cell carcinoma of the cheek, perhaps, and an infected cancerous wound with superadded bacterial infection, which is actually, giving out, manifesting as a foul smell. So for me, this is the disease, and most of us would actually concentrate our focus on this particular aspect only. But then when we talk about illness, we do look at the disease. But then what about the pain that is, that the patient is suffering from? What about the poor appetite that he has? You can see a small, if it is not very, I think, definite, but there is a Ryle's tube of this patient, okay? There's a feeding tube. He's being fed through that. He's losing weight. He feels tired all the time, there is absolute disfigurement of his face. Some kind of altered body image also. I wouldn't have tried to show you the whole picture, but then he does have an altered body image. The foul smelling wound is always oozing. you know. If you can see, the part of the lateral side of his tongue is almost visible through that aperture. And whatever he tries to eat through his mouth, it actually oozes out, it comes out from there. The saliva that is always inside our mouth, and we have a control, he doesn't have. It is just oozing all the time. And what about social alienation? You know, the children of perhaps the neighborhood had been told by their parents that don't go to that man's house, don't play with the children of that man, because he has been cursed with something, because of which he has this disease. And if you go there and play with his children, we all are going to get that. So this is social alienation. Nobody actually comes and asks him even what has happened. So the questions that this person might have is that, what will happen to my family? And why did God do this to me? So this whole thing is an illness. The spectrum is an illness. So if we need to take care of this patient, we'll have to, we'll have to uh, understand the suffering of this patient. The suffering being holistic suffering, or something which is very, very troublesome for the person as well as for the family. And while we understand suffering, we need to find out what goals of care are we going to sort out for this patient. Number one, definitely, if we understand suffering, we'll be better positioned to alleviate that suffering. There'll be some little bit of optimization of quality of life till the patient is living or till the patient dies. And then provision of comfort in death. I think these three things are extremely important for us to understand as caregivers, as treating doctors, as the healthcare staff. Unless and until we understand the suffering of a patient, we will not be able to provide a 360-degree care process for him. I'm not saying that we as doctors are obliged to, provide everything at one go. But we are the ones who can design the care process. In your later classes in this fellowship, you'll definitely come to know and understand about the importance of a team, of a multidisciplinary team, of a interdisciplinary team in palliative care. And that's where you will appreciate the complementing nature of all your team members. Maybe a nurse, maybe a social worker, maybe a volunteer, somebody from the community, somebody from the management of your hospital. So the crux of understanding suffering is to design the goals of care. And that is important, because if we do not understand suffering, we will not be able to provide the complete alleviation of suffering. And if there is a persistent and inadequate relief of suffering for such patients, the value of life for the sufferer would be always undermined, which we do not really want to do, right? Because we want the sufferer to value the life that is left with him, so that he comes up with all his wishes. He tells the family that, I need to go to this place. I need to visit these people with whom I have had a constrained relationship. divorced daughter might actually tell the father that I would like to seek your forgiveness. So all these things actually comes when you value life. And for a sufferer who's actually going to die, uh, undermining the value of life is equivalent to persistent and inadequate relief of suffering. So the alleviation of suffering is universally acknowledged as the cardinal goal of medical care. Unfortunately, perhaps, because of our time constraints, because of the kind of training that we have had, because of the numerous roles that we play in our lives, uh, sometime, somewhere we have perhaps lost this particular goal of medical care. But I'm sure after you do palliative care, after you start practicing palliative care, this is going to come back to you, because it is ingrained in all of us. It is there inside us. The only thing is that we need to tickle ourselves and find out how are we going to do that. Okay, so henceforth, the ability to recognize suffering is an acquired skill. So we will need to acquire the skill of recognizing suffering and understanding it, for a person who's actually given himself or herself to us for the rest of their life. So coming to a concept of palliative care, what is the concept? Before going to what we understand right now, I would like to share with you this particular slide, which gives us an old concept. So what happens is that there is a diagnosis of uh, a disease, perhaps, maybe, since palliative care most of the time is related to cancer. Let me just give you the example of cancer. So a person is diagnosed with cancer, and he goes to the oncologist, he goes through numerous tests, and then at one point of time, the oncologist decides that we're no longer going to treat you, because I think your treatment is not working, and my treatment or the oncology related treatment is not really helping you out. Henceforth, I declare you as a patient of end of life care. So, you're not going to have a lot of time from now on. So I would actually want you to go to a friend of mine who will look after you after this. So at that point of time, where the patient has uh, lost all hopes of recovering, the patient has lost all modes of treatment, and at that point of time, he's being shoved into somebody who will perhaps take care of him for another uh, 24 hours, or maybe 3 or 4 days, or maybe 1 week or 1 month at the max. And at the end of it, the patient dies. So this is an old concept where there is a staggered kind of a care for this particular patient, where we haven't understood the crux of understanding suffering at all, right? We just following a tradition where the patient comes to us, we diagnose him of a disease, and then keep on treating him till the time where the patient is no longer able to take it. The disease actually, overpass the life of the patient, and henceforth we are pushing him to something called palliative care, which might or might not help the patient. Okay, and the patient dies within no time. So this is the old concept. But what does the responsibility of a physician tell us? So as healthcare professionals, does our responsibility end with being able to cure and not to cure? Is this the only thing that we are bothered about right now? I really do not think so. We have to take responsibility of our patients uh, from the point of diagnosis till the patient is able to take certain treatment that is, aimed at curing the disease. And if there is no cure, how do we proceed with his life? What are the things that we need to make them understand, or make even ourselves understand for this patient? And at the end, when the patient leaves us, do we all also have a responsibility after that? Do we extend our help or extend something that gives solace to the people who are left behind by this patient? So that brings us to the modern concept of palliative care. And that is actually, you can see in this lovely graph, that the patient comes to us. We start the life prolonging therapies. For example, the oncology directed, the cure directed therapies. We start, and then if there is a cure in between, absolutely fine, lovely. If there is no cure and the patient actually goes towards an advanced stage of the disease, palliative care starts from the diagnosis and slowly increases in uh, breadth and length of the life of the patient, and when uh, the life prolonging therapies no longer give any cure to the patient, there is no role of these therapies. uh, Palliative care actually takes care of the end of life of that particular patient. And end of life, you will learn in your later classes. It may be, around 6 months. It may be around even around 1 year. So it doesn't really tell you that the patient is imminently dying. But then, for the benefit of the patient, the life prolonging therapies are being stopped. Okay, there must not be any kind of confusion when we stop life prolonging therapies. And when there is death of the patient, we extend our care as bereavement care for the family who's been left behind. For people of the social work background, they will also be interested in extended care of after bereavement, which is also rehabilitation services. Okay, so this is the modern concept of palliative care. And this is the thing that you will need to understand and take home today. So now, since we are doctors and professionals, we are bestowed with three great clinical skills in medicine. And, these are the diagnosis of a disease, and after diagnosis, treating the disease, and then prognosticating the disease also. But then I know many of you will actually agree with me that over the past 100 years, prognosis has gradually given way to treatment as the core clinical skill accompanying the diagnosis. So we have perhaps, ignored prognosis of a disease per se, because we are totally inside treating. And when we start treating, we start fighting the situation. And in the process, we are actually fighting nature. We are also fighting death. Okay. So I would like to give you a little bit about prognostication, because prognostication in palliative care is one important skill which will actually take you to 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 bigger heights, because you will understand that the skill of prognostication is not only beneficial for yourself, it is also beneficial for the patient. It is also beneficial for the whole life history of a disease, whatever disease may be, So the importance is to provide patients and their families with the right kind of information so that they can set their goals, they can set their priorities, and they can have realistic expectations of care. You don't once you start prognostication in the right way, I can actually predict there'll be less number of mob violence for hospitals, people coming and breaking down hospitals, people actually fighting with doctors, manhandling professionals, healthcare professionals. The most important thing that we need to realize in today's world is that if we are honest with ourselves, if we are honest with prognosticating, if we are honest in giving the right kind of information to our patients and their families, I think everything, the lost, I would say, maybe the virtue of the whole healthcare system is going to come back to us once again. So prognostication would also help patients to develop insights into their dying. If you will learn everything, about how to prognosticate and how to communicate prognostication in palliative care for such people who are dying, for people who are not also dying, for people who may not have anything else to do regarding the treatment. And those things you are going to be taught in your communication skills classes. And a lot of communication skills that you're going to develop after practicing in a daily basis with your patients, with the family members of your patients, you will come to appreciate the kind of weightage that it gives you in your professional life. I have actually gone through it, and that is why I'm giving you this particular concept. So prognostication will also assist clinicians into their decision making, as I've already told you, and then compare like patients with regard to outcomes. Okay, then provide a common language for healthcare professionals involved in the end of life care. There are many papers that have come out for a kind of a common platform or common language for healthcare professionals who are involved in end of life care. I will strongly recommend you to please go through the literature once, because your questions, the answers to your questions are all inside these research papers. There are a lot of things to be learned in end of life care communication, in end of life care team building, and so many other things, which is actually going to improve your skills while you take care of patients who are at the end of life. So Fries and Ehrlich have given us the relative probabilities of various outcomes of the natural history of disease. And that those are the 5 Ds of prognostication. For example, the disease progression or recurrence. If there is a patient who has come with a disease progression or a recurrence, uh, the for example, if you have a patient uh, who has a malignant ascites, and you have he had been done an ascitic tapping a few weeks back, he comes to you again with that, and then you tap the patient again for relief of suffering. Of course, the patient will have the question, how quickly will the ascites reaccumulate again? You must have your answer ready for that patient. I'm not saying that you will have to say, you don't have to bother about that. We are always there to, tap you. Our facility is 24 hours open. No, it's not that. You have to give that patient this particular information, that this is malignant. It is going to accumulate, reaccumulate, as quickly as possible till the time we keep on tapping it. So these examples are very important while we prognosticate. Death, how long do I have? This is a very common question. I used to be very fearful of this question at one point of time, but right now, I think after my little bit of experience in palliative care, I feel a little confident about how to handle this particular question. And I'm sure you all will also be able to do that. Disability, for those who have had a spinal injury, they're definitely going to ask you, will I be able to walk again? So you'll need to understand how to answer those questions. Have you prognosticated correctly? Are you actually going to give them a wrong answer? So all these things are very important. So look at these pictures. These are very disturbing pictures, but these are real pictures of my patients. And can you see the face of this, the patient on the upper right corner? Just look at the way that he's trying to wear his shirt, but he has a fibrosis just below his axilla, which is painful, and it is not allowing him to wear the shirt properly. So these are the nuances that you will perhaps need to capture while you are talking to the patient, while you are observing the patient. More of observations, more of looking at the expressions of the patient, more of reading between the lines of what the patient is trying to tell you. So these are the skills that perhaps you will need to reinvent in yourself. You already have those, you definitely have those, but perhaps reinventing them once again. Can you prognosticate this patient? He has a carcinoma of the penis. And let me tell you the history of this patient. Actually, when I was doing my fellowship in Pallium, India, I was a naive person in palliative care. I did not know anything about it. And I came to Pallium in India, and fortunately under Dr. Rajagopal and his excellent team of doctors who were teaching us. And this, we find a patient who came perhaps at 1:30 at night. And this patient has a carcinoma of the penis with severe neuropathic pain all throughout the surface of the body, except for the upper half perhaps, but then rest of the lower limbs and the scrotal sac, everywhere. It was extremely painful. Shripriya, can you give me 1 second, please? I have a call.
Sure, ma'am. Sure, please.
Yeah. So this patient actually came at around 1:30 in the night in emergency. He had severe pain in his lower limbs, in the scrotal sac, in and around the lower abdominal area, and he was unable to sleep. He gave a history of, if I remember correctly, around 6 months that he has not slept properly. He couldn't wear anything. His I think not even a lungi he was able to wear, because just at a touch of the cloth, he would have severe pain. So you can imagine, he used to stand on both his legs like this. He used to, lean on the wall, and then whatever sleep he used to get. So this is the condition of that patient. So how are we going to actually take care of this patient? See, we will perhaps need to innovate ideas. And that's where, uh, we need complementary support from nurses, from our team of volunteers, from our team of other doctors in this specialty. Okay. So the intent of me showing you this picture is that, we are the ones who can actually take care of this patient, where others would give up on such patients. The care process that we can give to this patient would be extremely valuable. And after you finish up with this fellowship course, I'm sure you all will have an answer to how to take care of such patients. What about this patient? I'm deliberately showing you very ghastly pictures because, unfortunately, cancer in India is, and in the world, is detected late. 80% of our patients come in a very advanced stage, and these kind of patients are a very common scenario in the palliative care ward, in the palliative care department, in the OPD. Okay, so when you start practicing palliative care, if you are in the oncology department as palliative care physicians, be ready to receive these patients. And for those who are in a non-oncology, non-malignant setup, you'll hardly find any patient, because unless and until the nephrologist gives up on dialysis and the neurologist gives up on a stroke, you will not get a patient. So that is the scenario in today's world. Starting from kids to very old patients also, palliative care has a role to play in everyone's life, everyone. So this brings us to a concept of total pain. Okay, so this particular term has been coined by Dame Cicely Saunders, and she came out with the concept that pain is not only physical, it has got a spiritual aspect, it has an emotional aspect, and it has a social aspect also. So physical aspect, you'll definitely see that it usually needs treatment with medications. There'll be a variable degree of distress because of the cause, and it also interferes with other aspects of life. Obviously, I mean, if I have a headache now and I have Shri Priya asked me to take another session, I will actually switch off my video and my audio and tell Shri Priya that Shri Priya, my net is not working. Okay. So physical problems always has a toll on one's life. But what about the spiritual ones? As we saw in the previous slides, in the patient that we had, the question of, why me? Okay. Have I done anything wrong to go through this particular disease? So, has God punished me like this? So, these are the spiritual questions that a person might have. At the same time, uh, you must have come across patients who have emotional distress because of such diseases. The feeling of frustration, hopelessness, certain anxiety disorders, depression is a common accompaniment with terminal illnesses. Okay. What about the social thing? The question of social alienation that the first patient that I showed you, what about that patient? Okay. So the distress over family members and carers, the loss of role of a certain person in the society. Okay, somebody who was perhaps one of the most popular persons in the locality right now has a nasopharyngeal carcinoma and is unable to go out and socialize with people. There's a taboo in the society that this particular person has cancer, so just avoid their household. So these are the four important aspects of total pain, which actually gives us a 360-degree of pain as total pain. But having said this, we cannot undermine palliative care to be just, holding hands, sitting with the patient, crying with the patient, which is definitely, many people in our society understand about. But for us, it is active medicine. There is always a scientific evaluation of physical problems like pain, breathlessness. And let me tell you, you will never be disappointed when you take care of pain, when you take care of breathlessness, because these symptoms and many other symptoms that you'll come across for palliative care patients are all can be all alleviated. There are wonderful, pharmacological as well as non-pharmacological methods through which you'll be able to take care of these problems. So, as we see, physical symptoms like pain, breathlessness, bleeding, hemorrhage, these are just the tip of the iceberg. And what we do not see generally are the issues that are embedded inside, starting from broken relationships to spiritual issues to sexuality issues. Sexuality is one thing that, that's a taboo still now. And I really do not understand why we cannot, give an importance to this issue. It's very, very important. A young lady, a married young lady, maybe around 28, has landed up in breast cancer, and the cancer is curable. She had undergone a mastectomy. She had undergone her set of radiations and chemotherapies, absolutely cured. But she's always in this insecurity of losing her husband because she feels incomplete all the while. I do not have a breast, My husband is no longer attracted to me. These are very important issues. And, I think as palliative physicians, it is our moral duty to address these issues upfront with the patient along with the family member. Okay, so I do this. Of course, you need to train yourself, you need to train your mind about even starting conversing about these issues. But once you do it, you train yourself first, and then you give it to the person who is in need of it. Okay, so I will urge you always to do that. Definitely, uh, uh, you know address sexuality issues. So this was an old thing, but then it's a very important landmark, because the World Health Assembly actually acknowledged that palliative care is an ethical responsibility of health systems, and it says that it is the ethical duty of healthcare professionals to alleviate pain and suffering, whether physical, psychosocial, or spiritual, and irrespective of whether the disease or condition can be cured. And that end of life care for individuals is among the critical components of palliative care. So, from this particular statement coming out from the World Health Assembly gave a strong boost to the palliative care community, the palliative care movement of the world. So, what are the implications of palliative care in serious diseases? For cancer, as I said, palliative care and cancer go hand in hand. The current cancer prevalence in India is around 2.5 million. New cancer patients registered annually is 0.9 million. The deaths due to cancer annually is 0.5 million. And 2/3 of our cancer patients present in the stage 3 and 4. And when we say stage 3 and 4, it is advanced cancer. Okay. So, many of my oncological friends, actually cancer specialists, they would get us into a kind of a tussle or kind of a debate, which of course healthy, saying that no, palliative care doesn't have anything to do with stage 3 and stage 4. They're all curable. We can give chemotherapy, we can give radiotherapy. Of course, my dear friend, we can do that, but please also let palliative care do a little bit for them also, because it is advanced stage. Okay, anything with metastasis is advanced cancer. So we need palliative care for every stage of cancer. We have a huge aging population. Mr. Modi must be actually screaming at the top of his voice that it is young India, young India, young India, but we are all growing old. And, at present we have 100 million elderly in India, and that is expected to rise to around 324 million by 2050. And that is going to constitute 20% of the total population of India. So you can imagine the amount of, elderly people in India. I'm going to be 50 next year, and next 10 years, I'm going to be a senior citizen. So I might at one point of time also need palliative care, and I'm ready for it, definitely. Okay. Interestingly, 60% of the elderly are affected by cancer. So these are the facts that has been put forward. I'm giving the resource here. You can actually go and look at this report. What about opiophobia? We learned about opioids in our pharmacology days, about the respiratory depression that the opioids cause. And whenever we had a question on opioids in our exams, it would always be what are the side effects and adverse effects of opioids. Personally speaking, in my class, we were never taught about the good effects of opioids. Okay. Oral morphine has a huge role to play in alleviating breathlessness, in COPD, and in respiratory illnesses, along with respiratory difficulty in malignant diseases also. So you're going to learn about these things in your next classes, definitely. But the point that I want to highlight in this slide is that because of the phobia that has been created in and around the use of opioids, people, cancer pain in India remains undertreated. Almost 1 million of our people are undertreated, have undertreated cancer pain. Just 0.4% of patients with cancer pain have, no access to oral morphine at all. Whereas, India is the largest producer of opium, and most of the opium is actually transported or is exported outside India. Everybody outside India gets morphine, and our people, despite of the fact that we produce morphine or we produce opioids, are devoid of morphine. Okay. But then, things have now changed. I'm going to talk about it a little later. We need to also understand the fact that, the National Crime Records Bureau had reported that more than 26,000 suicidal deaths in 2013 were due to hanging because of various ailments. So you can imagine the amount of unrelieved suffering and the frustration that leads one to hang oneself. So this is where we need to understand suffering, understand what that person is going through. And then only will we be able to justify our being as doctors or nurses or people of the healthcare fraternity. So there was a civil society driven drug policy reform for health and human welfare in India. This is an excellent paper. You can go through this, because this is the paper, this is the movement that brought about a huge change in the whole narcotic scenario of India, and has catapulted palliative care to a very different level in healthcare now. So present Indian scenario, there is a lot of good news. There is right now a national program for palliative care, which was created in 2012. And for those of you who are in the government setup, there is a mission called Mission Flexipool of the National Health Policy under the National Program for Palliative Care. If you need more details about what is included here, you can actually go to the NPPC site and take those information, because I think the Flexi Pool is one important fund, which is actually going to give you a lot of space to start palliative care in inside the dispensary or inside the particular health system that you're working with. And of course, that is the national health system. And then, the NDPS Act, or the Narcotic Drugs and Psychotropic Substances Act, uh, was a kind of a draconian rule. There were many nuances, many problems with that. And that Act of 1985 has now been amended in 2014. And the new act, the crux is that it gives easy access to opioids, especially to oral morphine. And that has really, really helped a lot of people to come out of suffering. There are a lot of education and training happening. I have given a very few smaller list of it. The Tata Memorial Hospital, All India Institute of Medical Sciences in New Delhi, and a lot more other, there is a DNB in palliative medicine also. If any of you would, like to pursue, please go ahead. Education for palliative never stops. So please do. The time that when we started palliative care, we had the MSc in palliative medicine and the diploma in palliative medicine from Cardiff University and many other universities outside of India. There is another one, which is the PhD in palliative care, offered by the Lancaster University, and I think 2 or 3 more universities of the US coming up with a PhD in palliative care. So if you are a certificate holder or a fellowship certificate holder in palliative care, you can actually go for a PhD in palliative medicine, palliative care. So the big question that we now have is, do we want to die like this? It's not about dying also. It is about our dignity. Are we going to be surrounded by these machines with beeps all around all the time? And I would want to die in this manner. Grow old. One of my grandson or granddaughter coming and giving me some little bit of water and smiles all around. My family just near me. I would like to die in this manner. So, this is something very, very close to my heart, because when we started learning palliative care, palliative medicine, and we started to practice, there were always hindrances, there were always obstacles. And when there are obstacles, you have to take a signal that you're actually doing something very good, So this particular proverb actually gives a lot of confidence, because you think you are too small to make a difference, then you have never obviously stepped in the same room as a mosquito. So some mosquito generally makes a difference in your sleep, in your night. So take yourself as a mosquito and bite everyone in and around you, so that they are actually they come to know about your power. They come to know about how you can bring about a difference in people's lives, and those especially who are perhaps in the end of their lives. So I close my talk here today. Thank you so much for a patient hearing.